Okay, good morning. So today we're going to deal with the urinary system. The urinary system consists of the kidneys, the ureters, and the urinary bladder. So the kidneys and ureters are duplicates, one on the right, one on the left. Then we have a single urinary bladder, and then a single urethra. And actually, the central organ here is the kidney, where filtration of the blood takes place. Not only filtration, but filtration and then reabsorption of most of the filtrate, as we will see in a moment. The remaining part of the urinary system is either conductive or it acts like for storage. So the urine that is formed in the kidney will pass to the ureters, and the ureters will transmit that urine to the urinary bladder. It will be stored there. There's nothing happening to the urine in the urinary bladder. It's unlike the gallbladder. In the gallbladder, there is a concentration of bile and there is a storage of bile. But here, there is no concentration of urine. The urine is just stored in the urinary bladder, and then after that, it will be transmitted into the urethra. So the main organ here is the kidney. And this is an overview of the functions of the kidney, and we are going to cover that in a moment. We are going to cover the structural components that contribute to these functions. So it regulates the composition of blood, the ions in the blood, sodium, potassium, calcium, chloride, phosphate ions. It also regulates the pH of the blood by regulating the secretion of hydrogen ion, reabsorption of bicarbonate, osmolarity of the blood, of course, by regulating the ions, and the glucose. There's a possibility of performing gluconeogenesis, the production of glucose from non-carbohydrate material. This can also be done in the kidney, so it can regulate the glucose, regulates the blood volume by either conserving or eliminating water. We will see that if there is more water needed to be reabsorbed, then this will be reabsorbed in the tubules of the kidney. Otherwise, the more water will be excreted to reduce the volume of blood. And so by this way, it can regulate the blood pressure. By controlling the volume of blood, it can regulate the blood pressure, and also by the production of renin. As we will see in a moment, there is an enzyme called renin that contributes to the regulation of the blood pressure and is produced by the kidney. And it excretes the wastes like the urea, the uric acid, ammonia, and drugs and foreign substances. So these are this is an overview of the function of the kidney. What happens is that 99% of the blood passing into the kidney will be filtered, and then it will be it will be filtered and then will be reabsorbed. 99% of it will be reabsorbed. So the blood that passes into the kidney will be filtered. 99% of it will be reabsorbed back. It's only 1% of it that is excreted in the urine. So let's deal with the anatomy of the kidney as the central organ here in this system. The kidneys are bean-shaped structure. There are two kidneys located in the lumbar region, and as you can see here, that they are very closely related to the posterior abdominal wall. They are in fact plastered to the posterior abdominal wall. They are retroperitoneal in the sense that there's peritoneum covering the kidney from the front and the side, but there is no peritoneum behind the kidney. So it doesn't have a double fold of peritoneum. It doesn't have mesentery. It is not intraperitoneal. It is retroperitoneal, lies behind the peritoneum, and I will show you that in a moment. It has an upper pole here that is related to the suprarenal glands, the adrenal glands. We have studied these glands before. And the medial side here of the kidney is called the hilus, or the hilum of the kidney. You have heard of the hilum, for example, hilum of the lung, and it is the place where structures pass in and out of an organ. So here we have a hilum of the kidney. On the medial side, the concave side of the bean, there is a hilum where the structures here, the main structures are vessels, renal artery and renal vein, and it is the pelvis of the ureter, the pelvis, this part of the distended upper part here, which give rise to the ureter. It's called the pelvis of the ureter. It passes through the hilum of the kidney. The lower kidney, as you can see here, the right kidney, as you can see here, is lower than the left kidney. And this can be understood because in the right hypochondrium you have this big organ, the liver. So it pushes the right kidney a little bit downwards. That's the reason why the right kidney is lower than the left kidney. And these kidneys, the upper poles of the kidneys are protected by ribs. The lower ribs, 11th and 12th ribs, they provide some protection of the kidney. Remember that on the left side, for example, the lower ribs also provide protection for the spleen when we dealt with the spleen. But here they also provide protection of the upper pole of the kidney. So they provide protection, but we should keep in mind, because of this relation to the ribs, then like in the spleen, fractures of the ribs, therefore fracture of lower ribs, in other words, might injure the kidneys because of their relations to the ribs, close relation to the lower ribs. This is a transverse section of the trunk. Here's the posterior part, that's the body of lumbar 2 vertebra, and you can see here that on either side, and very closely related to the posterior abdominal wall, are the kidneys. These are sections in the kidney. Here's the hilum on the medial side. You can see the blood vessels passing in and out of the hilum. The renal artery is a branch of the abdominal aorta. And the kidney is surrounded by a capsule of connective tissue that is transparent and firmly applied to the kidney, and it keeps the shape of the organ. But outside the capsule, you can see here this yellowish material, the fatty material. So there's fat. It's another capsule of fatty tissue, adipose tissue, that is present around the kidney. And this fatty material, it helps to keep the kidney in position, because otherwise the kidney might fall down. And so the fat is important to keep the kidney in position. And then more to the outside, externally, there is another capsule of connective tissue, of dense, irregular connective tissue called the renal fascia. So we have a renal capsule immediately applied to the kidney, then we have fatty material, and then we have the renal fascia, which is a tunic or a covering of connective tissue, and then more superficially is the peritoneum. All of these organs are covered by peritoneum of the posterior abdominal wall. They are plastered to the posterior abdominal wall by the peritoneum. Now this, as I said, the connective tissue that surrounds the kidney not only surrounds the kidney, but also passes through the hilum of the kidney into a space that is located inside the kidney, and this is called the sinus of the kidney. So the sinus is like a pocket which is inside the kidney. It's a space. If you remove the fat, it will be a space. But otherwise, in life, it is stuffed with fat. So you don't expect to find spaces, but it's all stuffed with fat. This fat extends from the fat around the kidney, goes into the kidney, into the sinus of the kidney, through the hilum of the kidney. And people who lose weight rapidly, then the amount of fat here will be much reduced, and the kidney might drop down. They call it nephroptosis. So it might drop down, and when the kidney drops down, because the surrounding fat is reduced, this might cause some kinking of the ureter. See here, these are the ureters. Because the kidney goes a little bit down, this might cause kinking of the ureter and might result in a ureteric colic and pain. So the renal capsule, adipose tissue, and then the renal fascia. And then all is covered by peritoneum. This is a section of the kidney, and you can see the parenchyma of the kidney. This is the region of the parenchyma of the kidney. It has an outer cortex and an inner medulla. The cortex is present to the outside, and the medulla, as you can see, is segregated into pyramids. These triangular shaped areas are called the pyramids. The base of the pyramid is bordering the cortex, and the apex of the pyramid is facing the central part. It's facing the hilum of the kidney. Here's the hilum of the kidney. You can see the renal artery, renal vein, pelvis of the ureter, and this is the fat that goes into the sinus of the kidney, the space, and fills in the gaps. Okay? And again, returning back, you have cortex, medulla. Medulla is in the form of pyramids. The apex of the pyramid is called papilla. And it's at the apex of the pyramid, at the papilla, that multiple of these large ducts, small ducts, they open here. And urine is produced. This trickles into these cup-shaped areas, which are called the calyces. By the way, here in between the pyramids, these areas, they are called the renal columns, and they are part of the cortex. So the cortex is not only confined to the peripheral part of the gland, but also part of the cortex is located between the medullary pyramids. Most of these medullary pyramids, they are formed of tubules, as you can see here. Most of them, they are formed of tubules. These tubules are for the reabsorption and secretion of urine. And at the end, we have the papillary tubules or papillary ducts that open at the tip of the papilla. So this is the parenchyma of the kidney. Then the drainage system of the kidney is formed of these cup-shaped areas. So these are called calyces. The single one is a calyx, and multiple are calyces. So we have two types of calyces. We have a minor calyx here. This is the cup-shaped, the small calyx, minor calyx, where the papilla of the pyramid projects into it, and urine is dripping here. About 3 or 4 minor calyces will join together to form a major calyx. So here's a major calyx, here's another major calyx, and here's another major calyx. 2 or 3 major calyces join together to form the pelvis of the ureter, or the renal pelvis. So this wide area here at the hilum of the kidney is called the renal pelvis. It's not the pelvis, it's not the bony pelvis, but it's the hilum, it's the pelvis of the ureter, or the renal pelvis. It's the basin-like. And then the renal pelvis, outside the kidney, it narrows and forms the tube-like ureter. So this is the drainage system of the kidney. Cup-like minor calyces lead into, the papilla opens at the minor calyces. Minor calyces lead to major calyx, or major calyces. 2 or 3 major calyces form the pelvis of the kidney, and then the pelvis will give rise to the ureter. And then the ureters will ultimately end into the urinary bladder. This is just the drainage system. There is no, the constituent of urine in these areas will not change. These areas, all of these, the minor calyces, major calyces, the pelvis of the kidney, the ureter, are all lined with transitional epithelium. Remember the types of epithelium we studied before? This is the transitional epithelium, the epithelium that stretches when it is distended, when the viscous or the organ it lines is distended. So the epithelium becomes stretched. So it is a stratified epithelium. It is a thick epithelium, so no absorption or exchange of material takes place here. The exchange of material takes place in the tubules of the kidney, as we will see in a moment. This is an actual kidney that has been dissected, and you can see here, the space here is called the sinus of the kidney. In life, it is stuffed with fat, and this fat also is present, forms an envelope around the kidney as well. And here's the hilum of the kidney. You can see the minor calyces, major calyces, and then the pelvis, and then the ureter. And this is the renal vein and the renal artery. So this renal artery is a branch of the aorta. The renal vein unlike in the GI tract, the renal vein, it drains into the inferior vena cava. It doesn't go into the portal circulation because there's no reabsorption, there is no absorption of nutrients taking place here. It goes to the systemic circulation. In the GI tract, the veins that drain the GI tract, they should go to the liver before reaching the inferior vena cava. But here, the renal vein, it is actually a tributary of the inferior vena cava. There is no absorption of nutrients. There is reabsorption of what has been filtered from the blood, but nothing new. Now the nephron, which is the functional unit of the kidney, is called the nephron. And each kidney has about 1 million of these nephrons. Usually, we use half of them in daily life. We use half of them, so there is a lot of reserve. That's why a person can live with one kidney. The transplantation is only required if that kidney is pathological as well. But otherwise, if the kidney is normal, then the person can live with one kidney because not all the nephrons are used. There are a lot of them. Each of these nephrons consists of what we call a renal corpuscle and a renal tubule. So a corpuscle and a tubule. Look at the corpuscle here. The corpuscle consists of a glomerulus and a Bowman's capsule. So corpuscle plus tubule form a nephron. The corpuscle is formed of a glomerulus and Bowman's capsule. The glomerulus is, in fact, it's a tuft of capillaries. A tuft of capillaries where filtration takes place. Here, blood comes from an arteriole here into the capillary and filtration takes place. The filtered fluid goes to the space here of the Bowman's capsule and then reaches the tubule, and in the tubule, most of it will be reabsorbed. The part that is not reabsorbed will go into the here. Oh, sorry. The part that is not reabsorbed will go into the papilla of the pyramid, into the minor calyx, major calyx, and then go to the ureter and the pelvis and the ureter. So in the nephron, the glomerulus consists of the capillaries, tuft of capillaries, and there is the Bowman's capsule. The Bowman's capsule, you can see it here. It has a space and it has a double wall, two walls. One of the walls is directly applied to the capillaries, and the other wall is called the visceral wall, and the other wall is called the parietal wall. It's double-walled. And now the tubule, if you look at the tubule, it consists of several regions. Of course, it's much longer than this diagram. Okay, this is just a diagram. It is formed of the first part of the tubule is folded on itself. It's convoluted, and so it's called the proximal convoluted tubule. And then it gives rise. The proximal convoluted tubule gives rise to a U-shaped loop of Henle. And so it has a descending limb and an ascending limb of the loop of Henle. And then you have another convolution here, which is called the distal convoluted tubule. The distal convoluted tubule is much shorter than the proximal convoluted tubule, but definitely it's longer than what appears in the diagram. Okay? And then these distal tubules, they will open into a collecting duct. So a collecting duct, there's a collecting duct for more than one nephron. It's common between multiple nephrons. But for each nephron, it has a proximal convoluted tubule, loop of Henle, distal convoluted tubule, and then it opens into collecting duct to which other nephrons has opened as well. These collecting ducts will become larger and larger and will form the papillary duct, and it's the papillary duct that opens here at the papilla of the pyramid. Here you can see this is the glomerulus. It consists of the Bowman's capsule and a tuft of capillaries. So these, the capillaries, they start as an arteriole, which is called afferent arteriole, the arteriole that brings the blood to the glomerulus. and then it divides into capillaries, and then an efferent arteriole. So here, this capillary network that is present in the glomerulus differs from capillary networks that are present elsewhere in the body. Remember the vascular system, cardiovascular system, and the capillary network. On one side, it's an arterial side. On the other side, it's a venous side. So you have an arteriole on one side, a venule on the other side, and in between them are the capillaries. Here, the capillaries that are present in the glomerulus are between an arteriole, afferent arteriole, and efferent arteriole. No veins are involved here, okay? Because the exchange that's taking place here is actually it's filtration of the contents of the blood, okay? That it's only filtration, no exchange. It's only filtration that takes place here. And the capillaries are lined with endothelial cells as usual, but these endothelial cells are covered with other cells which form the inner layer of the Bowman's capsule. This is the Bowman's capsule. As I said, it has an inner layer, visceral layer, and outer layer. The outer layer of the Bowman's capsule is formed by simple squamous epithelial cells. You can see them very clearly here. But the layer, the visceral layer, is formed of cells that have multiple processes, multiple feet. So they are called podocytes. Podocytes means that they have feet. Cells that have feet. Podocytes. These podocytes, they surround, by their feet, they surround the capillaries of the glomerulus, and they play an important role in filtration. One point I would like you to notice here is that the afferent arteriole is wider than the efferent arteriole. So this means that the blood which is present in these capillaries will be under higher pressure. Here it is wider, here it is narrower. So the blood which is present in the capillaries is under higher pressure, and this will help in filtration of the contents of the blood. This is a histological slide showing you the glomerulus. So these are the capillaries here, the tuft of capillaries, and that is the Bowman's capsule. Here's the outer layer of the Bowman's capsule. Here's the inner layer. Of course, you will not be able to see the processes of the podocytes in conventional histological sections. They are only seen under the electron microscopy. And this is how it looks like. See, that's the podocyte, and these are the feet processes surrounding the capillary. Remember that these capillaries are of the kind of fenestrated capillaries. If you look back at the cardiovascular system and the capillaries, we talked about three types of capillaries: continuous or non-fenestrated capillaries that are, for example, present in the brain and form the blood-brain barrier. And we have fenestrated capillaries where the endothelial lining has multiple pores, and this is where exchange of material takes place. And we have the other type of capillaries are the sinusoids. These are the white capillaries which are highly fenestrated, as well as the basement membrane is also fenestrated in the sinusoids. For example, the sinusoids of the liver. But here, the basal lamina or the basement membrane is non-fenestrated. It's only the endothelial cells of these capillaries that are fenestrated. So the filter here is formed by three structural components, because as I said, in the capillaries of the Bowman's of the glomerulus, filtration takes place. So what are the structural components of this filter? It is, first of all, it is the fenestrations of the endothelial cells. And here, these fenestrations are large fenestrations, so everything in the blood is filtered except the cells and the platelets. They are not filtered. Otherwise, everything is filtered. And then we have the barrier here, which is the basal lamina of the glomerulus. This will trap the large protein molecules. So they will return back to the blood. And then we have these slits, or the slit pores, which are present between the feed processes of podocytes. These are narrower, and they will prevent the passage of medium-sized protein molecules and return them back to the blood. Otherwise, everything is filtered and goes from here, from the podocyte, into the space, into the glomerular space, into Bowman's space, sorry. This is the space here, and this space is continuous with the proximal convoluted tubule and the remaining part of the nephron, where reabsorption of what has been filtered here will take place. And this will be more selective and controlled by several mechanisms in the body. So you can see here like 180 liters of blood are filtered every day, but they are reabsorbed, and only 2 liters of urine is produced. So about 99% of what is being filtered here is reabsorbed. And here the filtration takes place because one reason, as I mentioned before, is that the afferent arteriole is wider than the efferent arteriole. So the blood pressure here in the capillary network is high, and this will be helpful for the filtration. And it's the very thin membrane. There's very thin membrane here. The glomerulus has a very thin membrane, and it's a tuft of capillaries, so there is a large surface area of capillaries. It's not a single capillary. It's not like here in the diagram. It's a tuft of capillaries. And so there's large surface area, and this will promote the absorption. This will promote the filtration. Now the second thing here is that, as I said, that afferent arteriole forms a glomerulus and then the efferent arteriole. The efferent arteriole that arises from the glomerulus will divide into another group of capillaries. And these will form what we call peritubular capillaries, capillaries around the proximal and distal convoluted tubules. And some of them will go into the medulla, accompany the loop of Henle. They are straight capillaries. That's why they are called vasa recta. Recta, rectum means straight. So in other words, here again, we have another portal circulation, a renal portal circulation, because we have a tuft of capillaries here, and we have an arteriole, and then another group of capillaries. So this is another example in the body where we have a portal circulation. The most obvious example of a portal circulation in the body is in the hepatic portal circulation. And the second example, which you have studied before, is the portal circulation that is present between the hypothalamus and the posterior and the anterior pituitary gland. And this is another example of a portal circulation. A portal circulation, by definition, is that a circulation which is located between two groups of capillaries. The nephrons are of two types of nephrons. Most of the nephrons, actually, they are cortical nephrons. They are present in the cortex, and usually these nephrons, they have their loop of Henle present in the cortex as well as in the medulla. So most of the loop of Henle is present in the cortex. They are called cortical nephrons. The other type of nephrons, which is the minority, about 20% of the nephrons, they are located at the border between cortex and medulla. So they are juxtamedullary nephron, juxta, close to the medulla. So we have cortical nephrons and juxtamedullary nephrons. They are not present in the medulla. They are present in the cortex, adjacent to the medulla. And these are characterized by a very long loop of Henle that dips deep into the medulla, and they have the capacity, better capacity, to concentrate the urine than the cortical nephrons. There are substances which are called diuretics that will slow the renal reabsorption of water and result in diuresis, like the caffeine, which inhibits sodium reabsorption. Alcohol inhibits ADH, antidiuretic hormone. Remember the antidiuretic hormone? It's the hormone that is produced in the posterior pituitary gland and acts on the collecting ducts of the nephron and control the causes more reabsorption of water. So it's anti-diuretic because it increases the reabsorption of water that has been filtered in the glomerulus. In certain diseases, diuretics are prescribed, for example, to control blood pressure. And there are several types of diuretics which are used as in medication that act on different parts of the nephron, like proximal, distal convoluted tubule, or loop of Henle. Now, another point here about the kidney and the function of the kidney is an area or an apparatus that is called juxtaglomerular apparatus. So this one is juxtaglomerular, means it's close to the glomerulus. Don't confuse the juxtaglomerular apparatus with juxtamedullary nephron. Juxtamedullary nephron is located close to the medulla, and this juxtaglomerular apparatus, it is part of the nephron that is located to the glomerulus. And it's formed of two components. You can see the two components here. It is formed of a part of the afferent arteriole to the glomerulus and part of the distal part of the loop of Henle or distal convoluted tubule. So this is part of the renal tubule, the distal part of the tubule, and the afferent arteriole. When they come together, there will be some modifications taking place here, and together they are called the juxtaglomerular apparatus. So here the cells of the tubule, which is the distal part of the loop of Henle or the proximal or the distal convoluted tubule, you can see the cells will be modified. They will be longer cells, and the cells in the arteriole, actually, which cells? It's the smooth muscle. Remember the walls of the vessel? There's endothelial cells, then there are smooth muscle cells. In the arteriole, we have up to 5 layers of smooth muscle cells in the tunica media of the arteriole. These cells will become modified in the juxtaglomerular apparatus, and they act like they sense the pressure of blood. So we call them baroreceptors. They sense the amount of pressure in the blood, while here these cells, the modified cells of the distal convoluted tubule, will form what we call the macula densa, and they are chemoreceptors. They sense the osmolarity of the fluid that is present in the tube, and both of them, they synchronize their function to control the function of the kidney. So we have here the macula densa, which are chemoreceptors, and here the modified smooth muscle fibers in the arteriole, which form the juxtaglomerular cells. These juxtaglomerular cells will, in case of reduced blood pressure, if the blood pressure is reduced for any reason, like for example dehydration, loss of blood, this will result in reduction of blood pressure. They will release an enzyme which is called renin, and this renin will act on a substance in the blood called angiotensinogen and convert it into angiotensin. This angiotensin will have two functions. Either it acts on the circulation, on the blood vessels, and cause vasoconstriction, and if vasoconstriction takes place, this will elevate the blood pressure, or they act on the suprarenal cortex, and they cause the release of aldosterone. Remember the suprarenal cortex that has 3 layers, zona glomerulosa, zona fasciculata, zona reticularis. So they act on the zona glomerulosa and result in the production of aldosterone. Aldosterone will act on the kidney and stimulate the reabsorption of salts and water. So if water and salt is reabsorbed back to the circulation, this increases the blood volume, and again it increases the blood pressure. So whenever the blood pressure is reduced, then the renin, which is produced by the cells, by the juxtaglomerular glomerular cells will result in the activation of angiotensin. Angiotensin increases the blood pressure in two ways. Either it causes vasoconstriction or it stimulates aldosterone that acts on the kidney and increases reabsorption of water and electrolytes, increasing the blood volume, increasing the blood pressure, and then feedback mechanism will take place and everything will be, and the amount of renin will be reduced. As the blood pressure becomes normal, the renin will be reduced and a balance will take place. So this is how the kidney works. It filters the blood, reabsorbs most of it, okay? And so it can control what's going to be secreted, what's going to be removed from the body, as well as it secretes the waste material. After the kidney, we have the ureters, and they extend, as we said, from the pelvis of the kidney. They are retroperitoneal, and they open into the urinary bladder. The way that they open into the urinary bladder here, this is the wall of the urinary bladder. It's mainly muscular wall. So the ureter has an oblique course in the wall of the urinary bladder. So there's quite a good length of the ureter inside the wall of the urinary bladder, and this acts like a physiological sphincter. There's no valve here. There's no thickening of muscle fibers here, but because a long part of the ureter passes within the wall, passes obliquely, it doesn't go immediately straight into the wall, but passes immediately. So whenever the gallbladder is, whenever the urinary bladder is distended, then it will compress on that ureter, on that intramural part of the ureter, they call it, the part within the wall, intramural, and so reflux of urine will not take place. And the urine is always propagated either by the action of gravity or by the peristaltic waves that take place, or the hydrostatic pressure. There is urine being added as drop by drop, so there will be hydrostatic pressure with gravity, with peristalsis. Urine reaches the urinary bladder. When the urinary bladder distends, it cannot push the urine back into the ureter because of the presence of a part of the ureter within the wall, and this will be compressed as a physiological sphincter. This is how the ureter looks like in section. It has a transitional epithelium. Remember I said that all these passages are lined by transitional epithelium. They will not modify the content, they will not modify the urine. Urine is only modified in the tubules of the kidney, which are not lined by transitional epithelium. They are lined by simple epithelium. But here it is transitional epithelium, and then there are smooth muscle fibers, longitudinal and circular smooth muscle fibers, which help in peristalsis, and then there is a tunica adventitia, or an adventitial layer of connective tissue. This is where the urinary bladder is located. Here is a mid-sagittal section in the female and in the male. In the female, in both sexes, it is the urinary bladder. The empty bladder is present in the pelvis, behind the pubic symphysis. Remember the two hip bones, they come in the midline, and there's a cartilage, it's a cartilaginous joint, it's called the pubic symphysis. So they are located, whether in the male or in the female, behind the pubic symphysis. In the female, the urinary bladder is present in front of the vagina and below the uterus. And in the male, the urinary bladder is present in front of the rectum. Here's the rectum, it's present in front of the rectum and is located on top of the prostate. We're going to study the prostate next time when we deal with the male reproductive system. So in both sexes, the empty bladder is present in the abdomen, and it is like a hollow and distensible organ. It's just a reservoir for urine. Again, it is lined by transitional epithelium. Nothing happens to the urine inside it, no concentration. And inside of the urinary bladder, there is a triangular area here in the mucous membrane. It's called the trigone. And the angles of the trigone are formed by the openings of the ureters. So here's one ureter here, one ureter there, and the other opening here is called the internal urethral meatus. It is the internal opening of the urethra. Please don't confuse between the ureter and the urethra. The ureter is between the kidney and the bladder. The urethra is between the urinary bladder and the outside. And we have one urethra, two ureters. So here's the region of the trigone of the urinary bladder. It's a smooth area. Otherwise, you can see the mucosa here is set into rugae. Okay? The presence of rugae here in the mucosa, because it allows for distension. Whenever the bladder is distended, then there is quite a good amount of mucosa to be distended. The other part of the urinary bladder, apart from the mucosa, here is the mucosa, which is transitional epithelium, again. There is a submucosa, and there is the muscularis, very thick layer. And the muscle fibers are in different directions. Some of them are circular, some of them are longitudinal. There is another longitudinal muscle fibers, and they are required for mass contraction. When the bladder distends, they will contract and they will push the urine down into the urethra. Urine cannot go up into the ureter because of the presence of this physiological sphincter here. As these muscles are contracting in the wall, they will obstruct or close the ureter and prevent reflux. Of course, diseases might result in reflux of urine from the urinary bladder to the ureter. So again, I should repeat that this is a physiological sphincter here. It is no thickening of smooth muscle fibers. It's a physiological sphincter. And when the person has renal stones, for example, this is a common site of impaction of renal stone because it's a narrow place surrounded by muscle fibers. So a renal stone commonly impact at this location within the wall of the urinary bladder. The urethral sphincters, we have actual sphincters around the urethra. The first sphincter, which is thickening of smooth muscle fibers, that is located here in the neck of the bladder. So this is called the internal urethral sphincter. It surrounds the internal urethral orifice, and this is an involuntary sphincter. It is controlled by the autonomic nervous system. And then the urethra passes into what we call the perineum, into the urogenital diaphragm here of the perineum. And this perineum, or this diaphragm here, is formed of skeletal muscle fibers. These skeletal muscle fibers will constitute another sphincter, which is called external urethral sphincter. So we have two sphincters that control the urethra. The internal is involuntary and the external is voluntary. It's something similar to what we have studied in the anal canal, for example. There is internal anal sphincter, which is involuntary, made of smooth muscle fibers, and external anal sphincter, which is voluntary and made of skeletal muscle fibers. So when the bladder distends, this will send impulses to the sacral part of the spinal cord, and then the reflex is continued by autonomic fibers here, parasympathetic fibers from the sacral region of the spinal cord are going to supply the muscle of the urinary bladder, stimulate the muscle of the urinary bladder. These muscles, they have a special name. They are called detrusor muscle. So they will contract. At the same time, these impulses will result in relaxation of the internal urethral sphincter. So they will stimulate contract the detrusor muscle and relax the internal urethral sphincter. If the circumstances are not favorable at that time, then the brain is going to come into control and is going to send impulses under the will of the body to the external urethral sphincter. And the external urethral sphincter will prevent urination in this case. Okay? Otherwise, it's when the bladder distends, then you will feel the urge of urination, and if the brain allows, then urination will take place because of contraction of the trusor muscle, relaxation of the internal anal sphincter. Otherwise, the external anal sphincter can still control the urination. The urethra is, you can see it here in the female. It's very short. It's about 4 centimeters in length, and it's embedded in the wall of the vagina, anterior wall of the vagina, and opens between the vaginal opening and the clitoris. So it's straight, it is short, and that's why it's easy to pass a catheter in the female. But if you compare it to the male, it is not straight, it is long. Part of it passes into the prostate, which we are going to talk about next time, and this is called the prostatic urethra. And there is then another part which passes into the perineum. It's called the membranous urethra. It's a very narrow part. And then the other part passes into the penis, which is called penile urethra or the spongy urethra. So it is in 3 parts: prostatic, membranous, and penile urethra. It is long, it is not straight. That's why catheterization, that's to say passing a tube, like here, passing a tube through the urethra is much easier in the female than in the male. This is used whenever there's a narrowing of the urethra, or when sometimes in an unconscious patient or after some surgeries in the pelvis, they usually pass a plastic catheter here, and then this the end of the catheter will be in the urinary bladder. There is a balloon which is going to be inflated here to keep the catheter in position, and you can see the opening here, and so the urine will pass easily through the urethra to the outside. It will be much easier to be done in the female than in the male. The same route that is taken by the catheter, we can insert a cystoscope, which is a tube by which you can see the inside of the urinary bladder. And many operations nowadays are taking place through cystoscopy. So cystoscopy is not only diagnostic, it's also therapeutic. They can do some operations without the need to open the abdomen. They can do that through the urethra, and this is called cystoscopy. Any questions? Yes.